Hello, I'm Dr. Annalene Weston, dentolegal consultant at Dental Protection based in Brisbane. Welcome to RiskBites, a series of podcasts produced exclusively for members of Dental Protection. RiskBites looks at the key dentolegal risks and issues affecting dental practitioners across Australia and provides helpful advice and guidance on how to steer clear of them, leaving you free to provide safe and high-quality dental care for your patients. In this edition, we're going to focus on risk management for the whole team, and I'd like to invite my colleague and fellow dentolegal consultant, Dr. Simon Parsons, to discuss this topic with us. So Simon, you've raised an interesting issue for this podcast. Many of us feel that as clinicians, we're responsible for managing our own dentolegal risks. So why do we need to think more broadly and understand how our practice staff can impact on our level of risk?
Well, it's a really good question that many of us don't give a lot of thought to, Annalene. We seem to always assume that the risk of someone complaining about the care we provide a patient is directly a result of our own actions as clinicians. And yet what we're increasingly seeing instead is that patients are dissatisfied about their overall treatment experience. And I emphasize the term experience because that's the crux of it. Everything and everyone involved in the interaction between the patient and the practice. So this means that the way the initial point of contact occurs, such as how the phone is answered or how quickly and professionally the web query is responded to, sets the tone for everything that then follows. Our patients may well spend around half or more of their contact time with our practices engage in interactions with our reception, laboratory and assisting staff. And how many times don't patients reveal their concerns to our DAs or hygienists while we're not even in the room? How long do our patients spend in conversations at the front desk, organising their appointments and recalls and payments? And if we ignore all of those encounters, we can end up ignoring a big opportunity for success, or worse, opportunities where we and our team are failing to meet our patients' expectations.
So what are the areas where our staff can really influence, either positively or negatively, our risk?
Well, I like to call these areas the 3 A's. And to get a AAA rating, what I would recommend the 3 basic areas we should really concentrate on getting right are, and I'll do them in order now. The first is access. How quickly our patients are booked in when they feel they have a problem that's arisen, especially in the post-operative phase immediately after any care that we provided them. Patients expect some flexibility from us and often want to see us for what they feel is something of high importance. Sometimes they may only want 5 minutes of our time. They feel they need immediate assistance and we need to give them the reassurance that they can access our services in a timely manner. The second A is advice. And while our team are usually not qualified to provide clinical advice, they are the gatekeepers to sources of heaps of information. Things such as post-op instructions, the timing of their appointments, such as how long do I need to wait between root canal appointments, or is this pain normal? Do I need to come in sooner? Do I need to take my usual antibiotics before I come into this next appointment? All of those sorts of questions are often addressed to our team in the first instance. And when these are managed professionally, they are a huge value add to a positive and seamless clinical experience for our patients. But when done poorly, they can severely compromise treatment. This takes the heat off us to remember everything about our patients' care and can be profoundly protective for us medico-legally when this advice is done well. And then finally, the third A is action. Our team need to actually follow up queries. They need to confirm that laboratory work is back before the due date. They need to escalate any contacts with unhappy patients to us at the earliest possible convenience. For if we aren't told of a complaint from a patient, or about the patient who always cancels at short notice when they're due for an important review of a lesion, we actually end up with missed opportunities that can occasionally have disastrous consequences. Our staff need to be competent enough for us to delegate important tasks like this too. And ideally, a patient will know the name of one particular staff member with whom they should liaise whenever they come to the practice to ensure that their issues are dealt with. And our clinicians need a similar go-to person.
If you were to recommend one change we could make to have our staff help us reduce our risk, what would it be?
Perhaps the best contribution, I believe, is the capability to produce thorough documentation for ourselves in our practice. By that, I mean that they need to log calls to patients, they need to pass on messages to us in a prompt manner, showing that action mindset. And if they don't reach us, then they need to email us the issue so we can look at it after hours or when we're next back in front of a computer. They know how to do a proper tooth and perio charting with us. Our staff also type in our findings as we perform an examination on a patient and can help transcribe the conversation we have as we discuss treatment options with the patient or when the patient raises any concerns or questions about their care. If you don't have team members who can do this, then you're really accepting far more risk than you need to and giving yourself far more work. And when we're busier than what we want to be, we either make mistakes or simply neglect to complete important tasks. So my advice would be to train your staff until they can produce documents and records that are robust and useful, not just for organising efficient and effective care, but also for defending a complaint or claim should it ever arise.
Okay, Simon. So let's say we agree with you. Where might we start in getting our teams on board to help reduce our risk?
Well, it's my belief that the first step to take is to set the scene for what is important at your practice. What are your practice values and goals? Is it something like the customer is always right? Is it to get it right the first time, every time? Is it to have full books? Well, whatever it is, it will be the lens through which every action we take is viewed. So if, for example, you rely heavily on a flow of lots of new patients as you're building up your new practice, perhaps your biggest risk is negative feedback on social media, as this could easily kill a fledgling practice. If that's the case, you want to reinforce the need to ensure that every patient leaves the practice happy. You'll encourage and train your staff to get patients to air any concerns they have about their care before they leave. You'll have your staff document any niggly little hiccups or issues that arise along the way so you can act on them later before they become big ones. You will have an up-to-date website and answer new patient inquiries and requests for appointments within one business day. And you'll identify key members of staff with a passion in this area to drive and oversee this part of your practice so that the task is in good hands.
We often get feedback from our members that they really dislike having to deal with conflict in the workplace. Do you have any tips on how to address areas of weakness in a staff member?
Well, none of us are naturally good at dealing with issues that are outside our comfort zone. And for most of us, that includes dealing with stroppy and difficult patients, particularly when it happens out of the blue. My view is that most of us develop competency through practice, and practice will eventually make us much more adept at dealing with issues. So this means we need some exposure to conflict in a safe environment where we're unlikely to feel personally threatened. I see role plays at staff meetings as a great opportunity to build just that competency. We can put each other in hypothetical conflict situations and then work out what to say and what to do. If we stumble and muck it up, it doesn't matter. In fact, we learn valuable lessons from such experiences. We need to run through how we want these sorts of situations managed whenever we hire new support staff, though. We need to role model it when we deal directly with difficult patients. And we may need to provide one-on-one training and scripting for any staff member who struggles in this area to get them right up to speed. If we don't, they will remain a weak link when it comes to managing conflict situations constructively.
Thanks, Simon. So some of us are part of a large team of clinicians at a practice. Do you think this is a good thing or a bad thing in terms of its impact on our risk?
Well, as our practices grow larger and are often corporatized, we can gain some economies of scale and can create a really highly collegiate atmosphere. And that's a real bonus, as we can each have different skills that are complementary to one another. This can lower our risk by, for instance, delegating a difficult extraction case to the associate with the best surgical skills rather than taking it on ourselves and perhaps getting it wrong. The trade-off, of course, is in the risk of patients not experiencing continuity of care by seeing someone new at each checkup or encounter they have with us. The other major risk in my mind is failing to be notified of a problem with a patient due to staff being pulled in all sorts of different directions. Good practices will ensure staff are assigned to oversee specific clinicians' books and deal with issues in a timely manner for those patients. So it's not an insurmountable issue, but just needs some smarts to ensure it actually happens.
You've mentioned how staff turnover and absences increase our risk of complaint and claim. So what's the secret then in keeping our staff and dealing with issues in the absence of, say, an associate dentist at the practice?
It may sound trite, but happy staff rarely leave a workplace unless their personal circumstances demand it, such as ill health or a partner's work relocation. Happy staff feel valued and integral to the success of a practice. They're rewarded for moments of their excellence, and their happiness ends up being infectious within the team. The converse, though, is also true. Where we have miserable and sullen staff, particularly those at reception where the first point of contact occurs, we end up creating a vibe that is miserable and de-edifying for everyone in the workplace. So you need to meet regularly with your staff and check in with them just to ensure their well-being. You also need regular across-team communication, and that could be at a staff meeting, perhaps a morning huddle before each patient is seen, or on notices in the lunchroom. You need to celebrate success as a team because everyone should be contributing to that success and should therefore be rewarded and recognised for it when it occurs. And if there are issues, such as a key person being absent like that associate dentist, or if there's a complication in the care of a patient while someone is on leave, then we don't want to pass the buck, but instead as a practice we'll own it. We will try to accommodate the urgent patient of an absent associate rather than throw them under the bus by saying it is his or her problem to fix when they're next due in.
Thank you so much, Simon. That's incredibly helpful. And thank you all for listening. We do hope this podcast was helpful to you, and we look forward to speaking with you again in the future. Goodbye.